Today I'm presenting an audit on the results of patients with tetralogy of Fallots. This is an audit of last 10 years. So as we all know, congenital heart disease is one of the most common congenital disorders. It compromises 28% of the congenital birth defects. The birth prevalence of CHD is 9 per 1,000 live birth, which is also expected to increase with improved antenatal echo availability and delivery in multi-speciality hospital. This disease is about 1/5 of the patient is about 1/5 of them will still likely to have a serious birth defect requiring an early intervention in the first year of their life. And the demand and supply gap in India is because of India is a highly populous country with 1.48 million with a huge burden of disease. Although the facilities, we have centers with all these facilities to manage the problems, but they are few, mostly in the private sectors and not well geographically distributed. UP, being with a population of 240 million, has only 2 government sectors which properly cater such patients. One is our centers and another is AMU in Aligarh. To support this, PGI has joined hands with the government of UP and has embarked on the journey to create a world-class center for the management of such patients with congenital heart disease. The necessary approval for the creation of these 5 departments, starting with the post-doctoral advanced fellowship courses in the pediatric heart specialty, has already been completed. The first phase is yet to start in Feb 2024, and this whole group is supported by the Saloni Foundation. The soft launch was done on the 3rd October 2023 with the inauguration of the CVTS B ward with all dedicated staff. This is the photographs of the inaugurated B ward. 3 cheers to the department. And the inauguration has been done by the beloved director, Dr. Biman. The purpose of this audit is before we embark on this new project, we need to do a SWOT analysis. We are doing this audit on patients who have been operated on congenital heart disease in our department over last 10 years. As a sample, we have taken the most common complex congenital heart disease at Tetralogy of Fallots. Now, cyanotic congenital heart defect is an heart defect present at birth that reduces the amount of oxygen delivered to the body, most caused by the mixing of the oxygenated and the deoxygenated blood in the circulation. It may be associated with increased or decreased pulmonary blood flow. The other common congenital cyanotic congenital heart defects are TGA, transposition truncus arteriosus, tricuspid atresia, and TAPVC. The etiology of TOF is unknown. It may be multifactorial due to combination of genetic predisposition or environmental risk factors. Approximately 15 to 20% of infants with cyanotic heart defects are related to known chromosomal abnormalities that are trisomy 21, 13, 18, Turner syndromes. There can be environmental risk factors like maternal illness, including diabetes and phenylcytoketonuria, or maternal exposure to toxins, drugs, viral infections during pregnancies. Tetralogy of Fallots compromises of 4 defects, all which arises due to one problem, that is anterior septal deviation of the developing outlet septum. What happens is there is right ventricular output flow tract obstruction resulting into decreased pulmonary blood flow. There is override of the aorta. The aorta just saddles over the VSDs. Because of this, because both the ventricle blood are going into the aorta, causing mixing. There is right ventricular hypertrophy, and there is a large unrestricted VSD. This is a normal heart, extreme left. Middle is a tetralogy of Fallots. And this is a small video which represents the defect and what can be done. Just a small video of 3 minutes. I think we can, yeah. This is the VSD, which is present perimembranous towards the outlet. The blood is coming from the right atrium and there's a mixing happening going to the aorta. Here is the hypoplastic of the pulmonary alveolus as well as the pulmonary artery. because of which less blood supply goes to the pulmonary artery. The child is usually cyanotic at birth. And there's a right ventricular hypertrophy happening. I'm going to explain about the treatment in a brief in the later slide. This is a palliative care. We do a BT shunt for the neonates who have a very hypoplastic pulmonary artery with a abnormal anatomical or physiological problems. The principle behind doing the surgery is we need to increase the blood supply to the pulmonary artery. So we enlarge the annulus, put a transannular patch, or we enlarge the pulmonary artery. We close the VSD so that we don't want the mixing of the blood to be done. Here we go. So the main principle is to improve the blood flow to the lung, either widening or replacing the pulmonary valve and enlarging the passage from the right ventricle to the pulmonary artery. The closure of the VSD, as said, we don't want the oxygen and the deoxygenated blood to mix between the ventricles. Intervention for TOF, palliative is modified BT shunt as we saw now. Curative is total correction with relief of the RBOT obstruction and the VSD closure by rerouting the aorta to only left ventricle. Additional procedures are like coil embolization of MAPCAS, conduits from RV to PA, or pulmonary valve reconstruction. I'm just explaining the procedure, how we go surgically. We perform a median sternotomy. Patient is fully hyperinized. We go on aortobicual cannulation. Ascending aorta cardioplegia cannula is inserted, followed by cross clamp, and intermittent cardioplegia is given. All the procedures are done through combined right atrium and P approach. The parietal band of the infundibulum muscle is cut, and adequate sizing is done with the Hagar dilator depending upon the weight of the child. The pulmonary valve is then inspected. Valvotomy is done if required. VSD is closed using a Decron patch with either a continuous or an interrupted suture, redirecting the LV blood directly to the aorta. Transannular patch or the patch enhancing the left or right PA is done if required. Pulmonary valve is reconstructed using autologous untreated pericardium to create a non-obstructive competent valve. All the closures of the cardiac, or after the closure of the cardiac chamber, the aortic cross clamp is released and the patient is comfortably weaned off from the CPB. Our is a retrospective study. It's from Jan 2010 to December 2020. Total cardiac surgery that includes adult as well as pediatric, all the spectrum is 6,584. Surgery for congenital heart disease is 2018. Number of surgeries for only cyanotic heart disease is 514. And surgery for only TOF is 267. So today we are concentrating on only surgeries for top, that is 267. All the data was collected from the HIS. That was demographic, operative details, echocardiography, morbidity, mortality. All the discharge summaries were gone through and the OT notes. Long-term results are not.
Vasudha, can you be a little louder? People
Sorry?
are not able to hear. Can you be little?
Am I not audible?
Yeah, so some issues.
Is it?
Maybe you can be closer to the mic.
Am I so far? Okay. Am I audible now? Yeah, okay. Sorry for that. So long-term results are being collected as we are trying to contact all the patients, but it is not this part of the presentation. The results of total correction is the mean age is between 8 to plus minus 6 years. Total number of patients was male patients were more than female. Cardiopulmonary bypass time was 100 minutes plus minus 40 minutes. Aortic cross clamp time was 58 plus minus 28 minutes. The CPB flow was as per the BSA and the temperature using for the CPB. The cardioplegia which we used was St. Thomas, which was repeated every 20 minutes. That depend upon the body weight of the patient as well. So patient was cooled to 28 degree, flow was reduced to 2/3 of the required, and the cardioplegia was repeated more frequently. 59 patients required pre-op embolization of the MAPCAS. 149 patients required transannular patch or a branch pulmonary artery patch to achieve an adequate RVOT. 168 patients required pulmonary valve reconstruction. And in our department, the prominent study and the operation is done by Dr. Shantanu Pandey regarding this. So he has more experience on this. Perioperative mortality is 16%. That is quite high as per the literature. Ventilation time, inotropic requirements, and total drain, they were all the predictors of the mortality. More the CPB time, more the cross clamp time, more the ventilation, more the ICU, all leaded to the mortality. So the mortality, as I said, was higher in our audit. So what we understand is the children coming to us is mainly of the higher age, resulting in coagulopathy and collateral development, which has already led to organ dysfunction due to long-standing cyanosis. We can better manage it by using plasmas and priming the circuit, by using heparin bonded circuit. And instead of using cardioplegia like St. Thomas, we can use a longer duration cardioplegia like Del Nido, which works for 60 to 80 minutes and doesn't require to interrupt the surgery to give the cardioplegia every 20 minutes. Better pre-op delineation of the anatomy was done by preoperative CT scan. Pre-op embolization of MAPCAS can be done. More use of pulmonary valve reconstruction. Not all surgeons do that in our department. Routine use of intraoperative TOE and dedicated nurse 1:1 for better post-op care and to pick up early post-op immediate complication by doing an active involvement with the cardiologist for transthoracic echo. We also need a dedicated intensive care staff, which we don't have. We as a cardiac surgeon manage the ICU as well after the surgery. We also need to have an early institution of CRRT if required, and proper and rational antibiotic use. This is a rough plan how we go about tetralogy of Fallots if the child is ductus dependent. If not, the neonatal operation having a hypoplastic PA and an abnormality in coronary artery, always go for a modified BT shunt. As well as if the child has adequate PA, we go for a complete correction. Similarly, if it is non-ductant dependent with no symptoms, the elective surgery is done by the age of 6 months. If hypoplastic PA, then modified BT shunt. If adequate pulmonary size artery, then complete repair. This is a picture taken by our department while creating a competent pulmonary valve after transdermal patch. The most of the work done regarding pulmonary valve reconstruction is by Shantanu Pandey sir, and he has published all his data. These are the papers he has published. So he has more exposure in this group of patients. He has also contributed much for the transmural funded project, which for determination and establishment of key molecular therapeutic approach for remodeling of pericardial heart valves for TOF. The project is of 3 years and only 1 year has been completed till now. The problem which we understand on the TOF cohort is like the mean age which we get patients to operate is 11 years. Literature shows that we should be operating this patient between the age of 2 and 3. There is, by that time, there is extreme RV hypertrophy. So decreased compliance of the RV post-op leads to the failure. High filling pressure always leads to the organ damage. We observe that severe RV systolic pressure, even with the gradient across the RVOT of less than 30, happen because there might be thrombosis in the terminal PA due to polycythemia or the collateral associated with the sectoral pulmonary hypertension. Problems encountered during the surgery is long-standing cyanosis leads to coagulopathy, high hematocrit, so organ dysfunction, and myocardial fibrosis and myocardial dysfunction. Related to collaterals, that's why we need to coil the collaterals before, because the increased blood flow during the surgery can make the surgery more difficult, and it will be difficult for us to preserve the myocardium. And increased pulmonary blood flow after surgery results into pulmonary edema. We face such challenges because of financial constraints, as we see in our patients. The health-seeking behavior of the community is not that great. There is lack of awareness as well as in the family coming from the remote areas. There are still gender bias. And finally, we have lack of man-trained powers, and we have less people to take care of such. I give my gratitude to Department of Cardiology, Anesthesia, Transfusion Medicine, Neonatology, CCM, Department of Radiology, Gastroenterology, and lastly the CVTS, Perfusionist Ward, OT, ICU staff, and the residents. Thank you so much. Just on a lighter note, while coming to the hospital, I just realized one thing, that when I was an MBBS student, I never liked this Tetralogy of Fallots. I was always a person who used to avoid this question. And to my bad luck, this was a question coming to my final exam, and I didn't know what to write. So I understand why is this so complex, when as a student, I was having so problem in even remembering it. So I know how complex it is still now in my mind. Thank you so much.